A 44-year-old man who works as an investment banker comes in with a headache which feels like a band around his head and is worse at the end of the day. He would like to find out more about the headaches and their treatments. He says he has tried paracetamol, which has not helped, and asks whether he would be able to try oxygen for this headache. He says that one of his colleagues at work also suffers from headaches which are treated with oxygen. Oxygen is used as a treatment for which one of the following types of headaches? So this banker is most likely having tension headache given the area is a band area around his head. His friend, however, being treated with oxygen is typical of cluster headache. A cluster headache results in intense pain around one eye, which is often accompanied by lacrimation and redness of the eye. It usually starts 15 minutes to 2 hours. You usually last 15 minutes to 2 hours. Treatments for this include triptans and oxygen. The gentleman in this question has tension type headache, which is not treated with oxygen. He should be asked more about how he could relieve some of his stresses and also consider using alternative analgesia. Migraines, postcoital headaches, and temporal arthritis are not usually treated with oxygen. Okay, let's look at 9CKS for the management of tension headache and the management of cluster headache, shall we? Headache tension type. So here's a summary. Tension type headache is a common primary headache disorder which can be categorized into infrequent episodic tension type headache, less than 1 day of headache per month; frequent episodic tension type headache, at least 10 episodes of headache occurring on average 1 to 14 days per month for more than 3 months; chronic tension type headache, 15 or more days of headache per month for 3 or more months. Tension type headache typically presents with generalized headache, usually described as a pressure or tightness around the head, which often spreads into or arises from the neck; mild to moderate intensity headache, which can last minutes to days and is not aggravated by routine physical activity such as walking; pericranial tenderness, which may be elicited on manual palpation. The cause of tension type headache is unknown. Peripheral pain mechanisms are thought to play a role in episodic tension type headache, whereas central pain mechanisms are increased pain sensitivity may be important in chronic tension type headache. Serious causes of headache such as trauma, vascular disorders, and neoplasm should be considered as part of the differential diagnosis. Management of episodic tension type headache includes simple analgesia such as paracetamol, aspirin, or non-steroidal anti-inflammatories, taking into account comorbidities and risk of adverse effects; avoidance of opioids; identification and appropriate management of associated comorbidities such as mood disorders, chronic pain, and sleep disorders; provision of patient information on tension type headache and avoidance of medication overuse headache. Preventative measures that may be considered for chronic tension type headache include a course of up to 10 sessions of acupuncture over 5 to 8 weeks, low-dose amitriptyline off-label indication, referral to or discussion with a neurologist or GP with a special interest in headache is indicated if first-line measures in primary care fail or there is uncertainty about the diagnosis or treatment. Let's look at the management. How should I manage tension type headache? If the person has any red flags or for a serious secondary cause of headache, refer to secondary care with urgency depending on the clinical situation. For information on red flags, see the section on warning features of serious causes of headaches in the CKAS topic Headache Assessment. If clinical features are consistent with episodic tension type headache, offer simple analgesia such as paracetamol, aspirin, or non-steroidal anti-inflammatory, taking into account comorbidities and risk of adverse effects. Advise the person to take a therapeutic dose as soon as possible after onset of attack. For further information, see 9 CKS topics on analgesia, mid to moderate pain, and NSAIDs prescribing issues. Do not offer opioids. If needed, reconsider the diagnosis. For further information, see CKS topic on headache assessment. Identify comorbidities that may be associated with TTH, tension type headache, such as stress, mood disorders, chronic pain, and sleep disorders, and manage appropriately. For further information, see the CKS topics on depression, generalized anxiety disorder, obstructive sleep apnea syndrome, osteoarthritis, and rheumatoid arthritis. If clinical features are consistent with chronic tension type headache, consider preventative treatment. With a course of up to 10 sessions of acupuncture over 5 to 8 weeks, acupuncture may not be easily accessible in primary care. Pharmacological prophylaxis with low-dose amitriptyline 10 to 75 mg daily, taking into account comorbidities and risk of adverse effects. This is an off-label indication. For people who do not respond, discontinue treatment and discuss with neurology. For people who do respond, attempt withdrawal of medication if improvement is maintained for 4 to 6 months. For further information, see the prescribing section in the 9 CKS topic on migraine. Provide written and oral patient information on tension type headache. Patient information on tension headaches is available on the NHS website. Advise the person on the risk of medication overuse headache. People with frequent or chronic tension type headache may overuse medications to treat attacks and develop medication overuse headache. For further information, see the CKS topic on headache medication overuse. The coexistence of tension type headache and migraine without aura or medication overuse headache is suspected. Advise the person to keep a headache diary recording frequency, severity, characteristics, and duration of attacks, along with effectiveness of medications used to help differentiate between headache types. For further information, see 9 CKS topics on headache assessment, headache medication overuse, and migraine. If uncertain about diagnosis or management of first-line measures in primary care fail, discuss with a neurologist or GP with a special interest in headache. So basically the normal type of tension headache, right, the not so severe one, you would offer simple analgesia such as paracetamol, aspirin, or NSAIDs. No opioids in this case. Whereas if it's a chronic, clinical features are consistent with chronic tension type headache, which is more than 15 days per month for more than 3 months, then you will consider prophylaxis for the headache, which includes either acupuncture or amitriptyline. Yeah. And the rest is talking about treating the cause of the tension headache. It might be due to stress. Where is it? Here. Identify comorbidities that may be associated with tension type headache such as stress, mood disorders, chronic pain, and sleep disorders. Stress, mood disorders, chronic pain, and sleep disorders. Okay. So tension type headache, give simple analgesics, paracetamol, aspirin, or NSAIDs. If this is the chronic type, you might want to consider acupuncture, or amitriptyline. And you want to treat comorbidities that may be associated with tension type headache, such as stress, either physical or psychological, mood disorders, chronic pain disorders, or sleep disorders. Stress, mood, sleep, chronic pain. Yeah, okay. So that's the management for tension type headache. Let's look for management of cluster headache. So cluster headache is rare but severe primary headache disorder. It is the most common trigeminal autonomic cephalalgia. It is characterized by recurrent attacks of one-sided pain in or around the eye or temporal region, ipsilateral autonomic symptoms such as conjunctival injection and or lacrimation, nasal congestion and or rhinorrhea, eyelid edema, forehead and facial sweating or flushing. Brief attacks of less than 3 hours duration. Cluster headaches can be episodic with attacks occurring in periods lasting from 7 days to 1 year and separated by pain-free periods lasting at least 1 month. Chronic with attacks occurring for more than 1 year without remission or with remission periods lasting less than 1 month. The cause of cluster headache is not fully understood. In some people, there may be an interaction between genetic and environmental factors. During assessment of a person with suspected cluster headache, clinicians should be alert for clinical features which may indicate a serious secondary cause of headache. Referral to or discussion with a specialist with urgency depending on the clinical situation is recommended for people who have clinical features suggestive of a serious secondary cause of headache or where diagnosis is uncertain, present with a suspected first bout of cluster headache, are pregnant or breastfeeding, do not respond to management in primary care. Management of an acute attack of confirmed cluster headache in primary care involves offering a subcutaneous or nasal triptan, such as sumatriptan, by subcutaneous injection to people aged over 18 years, avoiding paracetamol, non-steroidal anti-inflammatories, opioids, ergots, and oral triptans. Offering short burst oxygen therapy, 100% oxygen at a flow rate of 12 to 15 liters per minute via non-rebreather mask for 15 to 20 minutes, if not contraindicated. Advising the person on avoidance of triggers, advising the person on the risk of medication overuse headache, identifying and managing any comorbidities such as depression, anxiety, and sleep apnea, provision of written and oral patient information on cluster headache and support organizations, referral to a specialist if uncertain about diagnosis or management, or first-line measures in primary care fail. Let's look at the management. So how should I manage someone with suspected cluster headache? If the person has red flags or a serious secondary cause of headache, refer to secondary care with urgency depending on the clinical situation. For information on red flags, see the section on warning features of serious causes of headache in CKS topic Headache Assessment. If clinical features are consistent with cluster headache, refer to or discuss with a neurologist or GP with a special interest in headache. In all people presenting with first bout of cluster headache, confirmation of diagnosis by a specialist is required and may involve neuroimaging. Preventative treatment such as verapamil may be considered. People with confirmed cluster headache who have developed new symptoms or signs suggestive of a serious underlying secondary cause. Pregnant or breastfeeding women. All pregnant women with cluster headache should be referred to a specialist in neurology. Why is that? Is sumatriptan contraindicated in pregnancy? Let's find out. No, we're not talking about tablets, we're talking about injected forms. Migraine attacks with or without aura, cluster headache. Only be used where there is clear diagnosis of migraine or cluster headache. It's a selective serotonin 5-HT1 agonist. Sumatriptan has been demonstrated to be specific and selective 5-HT1D receptor agonist with no effect on other 5-HT receptor subtypes. The vascular 5-HT1D receptor is found predominantly in cranial blood vessels and mediates vasoconstriction. In animals, sumatriptan selectively constricts the carotid arterial circulation but does not alter cerebral blood flow. The carotid arterial circulation supplies blood to the extracranial and intracranial tissues such as the meninges, and dilatation and/or edema formation in these vessels is thought to be the underlying mechanism of migraine in men. In addition, experimental evidence from animal studies suggests that sumatriptan inhibits trigeminal nerve activity. Both these actions, cranial vasoconstriction and inhibition of trigeminal nerve activity, may contribute to the anti-migraine action of sumatriptan in humans. Sumatriptan remains effective in treating menstrual migraine, in other words, migraine without aura that occurs between 3 days prior to and up to 5 days post onset of menstruation. Sumatriptan should be taken as soon as possible in an attack. Clinical response begins 10 to 15 minutes following a 6 mg subcutaneous injection. Because of its route of administration, sumatriptan may be particularly suitable for patients who suffer with nausea and vomiting during an attack. Post-marketing data from the use of sumatriptan during the first trimester in over 1,000 women are available. Although these data contain insufficient information to draw definitive conclusions, they do not point to an increased risk of congenital defects. Experience with the use of sumatriptan in the second and third trimester is limited. Evaluation of experimental animal study does not indicate direct teratogenic effects or harmful effects on peri and postnatal development. However, embryo-fetal viability might be affected in the rabbit. Administration of sumatriptan should only be considered if the expected benefit to the mother is greater than any possible risk to the fetus. So no clear conclusion from studies yet, especially in second and third trimester. That's why you want to refer to neurology. Okay, manage acute bouts of confirmed cluster headaches. If appropriate, offer subcutaneous or nasal triptan to people aged over 18 years. Options include sumatriptan by subcutaneous injection for adults, initially 6 mg for one dose, followed by 6 mg after at least 1 hour if headache recurs. People not responding to the initial dose should not take the second dose for the same attack, maximum of 12 mg per day. Or there's the other option of sumatriptan by intranasal administration for adult aged 18 to 65 years, initially 10 to 20 mg dose to be administered into one nostril, followed by 10 to 20 mg after at least 2 hours, only if the headache recurs. People not responding to the initial dose should not take a second dose for the same attack, maximum of 40 mg per day. Or the third option, zolmitriptan by intranasal administration, unlicensed indication for adult, 5 mg dose to be administered as soon as possible after onset into one nostril only, followed by 5 mg after at least 2 hours, only if symptoms recur, maximum 10 mg per day. For further information, including contraindications, see the prescribing section in the CKS topic of migraine. Do not offer paracetamol, non-steroidal anti-inflammatories, opioids, ergots, or oral triptans for the acute treatment of cluster headache. I'm assuming that these medications will not work for cluster headache, so if you offer them, you will the patient will lose confidence in you because this headache is really severe, and then he might he'll suffer more. So should we go for the most effective one, which is either short burst oxygen therapy or triptans, intranasal or subcutaneous triptans. Offer short burst oxygen therapy. If not contraindicated, provide 100% oxygen at a flow rate of 12 to 15 liters per minute via a non-rebreather mask for 15 to 20 minutes. Home oxygen can be provided through the home oxygen order form. Advise the person on avoidance of triggers. Cluster attacks may be triggered or exacerbated by behaviors such as alcohol consumption and smoking. For further information, see nice CKS topics on alcohol, problem drinking, and smoking cessation. Advise the person on the risk of medication overuse headache. People with chronic cluster headache may overuse symptomatic medications to treat attacks and develop medication overuse headache. A headache diary recording frequency, severity, duration, and characteristics of attacks can help differentiate between headache types. For further information, see CKS topic on headache medication overuse. Identify and manage comorbidities. Several conditions including depression, anxiety, sleep apnea may coexist with cluster headache. Ensure that comorbidities are adequately treated. For further information, see CKS topics on depression, generalized anxiety disorder, and obstructive sleep apnea syndrome. Provide written and oral patient information on cluster headache and support organizations. Patient information on cluster headache is available on NHS A to Z website. If uncertain about diagnosis or management of first-line measures in primary care fail, discuss with a specialist in neurology. So in conclusion, you treat tension-type headaches with either short burst oxygen therapy, which is 12 to 15 liters of oxygen given via a non-rebreathe mask for 15 to 20 minutes, or you give intranasal or subcutaneous triptan, for example sumatriptan. Other than that, things to advise the patient is to avoid potential triggers such as smoking and alcohol, and treat comorbidities such as mood disorders, stress, sleep apnea, sleep disorders, anxiety, and we need to know when to refer to secondary care, which is when secondary cause of headache is suspected. Maybe you suspect that this headache is caused by a mass in the head space occupying lesion, then you have to refer. Or this is the first time they are presenting with first time they are presenting with cluster headache, you want to refer to a GP with specialist knowledge in headaches, or a neurologist, or in pregnant women also you will want to refer, where they might be given prophylactic treatment such as verapamil. Right, that's all.